classification of non-small cell lung cancer. The TNM staging system is an established uniform method of staging lung cancer, and it depends primarily on the anatomic extent of the disease. It helps in treatment planning, provides prognostic information, and assists in evaluation of treatment response. Also, it facilitates a uniform exchange of information among various treatment centers and treating clinicians. Currently, we are using 8th edition of TNM for staging lung cancer that was released in 2017 by the International Association for the Study of Lung Cancer. The main updations in this edition from the previous 7th edition were related to the tumor size and extent of involvement, that is T descriptor, and the subclassification of M descriptor while classifying extrathoracic metastasis. Generally, we use the terms cTNM or iTNM, which means clinical TNM or imaging TNM, which is the pre-treatment staging of the lung cancer. But also, we are using the terms pTNM, which means pathological TNM, yTNM, which means when we use TNM staging to assess the response to therapy, and rTNM when the staging is done during the recurrence of lung cancer. CT and PET-CT are the main imaging modalities used for TNM staging. While describing the T descriptor, every centimeter of the tumor size counts. And remember that there is separate criteria for solid nodules, subsolid nodules, which can be part solid or pure TGO, and the multiple tumor nodules or lesions seen in one lung or both the lungs. This is the chart depicting the various categories of T descriptor ranging from T1 to T4. I won't be able to go into the detail of each of these categories separately due to paucity of time, and also I presume that you must be aware of these different T descriptors. So what I will be covering will be the few contentious issues or where some clarity is needed while reporting or giving TNM staging to various lung tumors. One such instance is when we get multiple T descriptors in one tumor nodule. So in these categories, we have to use the highest T descriptor. For example, if the tumor size is small, but the T category for the invasion is higher, so we have to give the overall T descriptor as depending upon the invasion or the extent of the tumor, and vice versa. This is one example. Like here is a tumor sitting here. If you measure the greatest dimension of this tumor is approximately 1.5 centimeter, which makes it to be a T1B category. But if you notice, there is also associated atelectasis. So which one makes this tumor to be T2? So what will be the final T descriptor that we have to give to this tumor? It will be T2, as we have to give the highest applicable T descriptor. Whenever there is a discrepancy or there are two T descriptors applicable, we have to use the highest T descriptor. Another limitation in the measurement of tumor size is that CT scan generally has been shown to overestimate the tumor size, especially for non-small cell lung cancers upon the pathological review. Then there can be inter- and intra-observer variation while reporting the size of the lung tumors, lung nodules, and other technical or patient-related parameters such as size thickness, reconstruction kernel, patient's level of inspiration at the time of scan acquisition. These can also contribute in the variable reporting of the nodule size on CT scan. Sometimes we can also get necrosis or cavitation within the tumor nodule. The tumor nodule can have ill-defined margins and post-obstructive pneumonitis or radiation changes in the surrounding lung, which may create a challenge to accurately and precisely measure the tumor size even to the most experienced radiologists. For instance, in this case, you can see there is a tumor sitting here which has a lot of speculation in the surrounding lungs. Also, you can see there is a small area of a band-like or plate atelectasis in the anterior portion. Sometimes these tumors can be difficult to accurately measure if we are not able to define the edges which need to be measured for the tumor size. In the subsolid nodules, which can be part solid or pure GGO, the most difficulty comes in measurement of part solid nodules, especially the measurement of the solid component, because sometimes there can be presence of multiple complicated or scattered solid areas within one nodule rather than a single focus of solid component, and there exists no consensus on how to make the uniform measurement of these solid component tumors in the subsolid nodules. So, for instance, in this case, you can see a part solid nodule which has some part as ground glass and some part as solid component. Sometimes there can be multifocal solid components. In this case, still you can measure the size, but sometimes these solid components can be discrete, looking like multiple solid nodules within one nodule. So, in these cases, the measurement of the accurate or the exact size sometimes can pose a challenge. In end descriptor, there is no change from the 7th edition, as I've already told you. Any lymph node which is more than 1 centimeter in short axis diameter on CT scan is considered abnormal. N classification in the HTNM, where N0 means no lymph node metastasis, N1 means ipsilateral, peripheral, intrapulmonary or higher node metastasis, and 2 is ipsilateral mediastinal or subcranial lymph node involvement, and N3 is ipsilateral or contralateral supraclavicular or group of lymph nodes or contralateral mediastinal or higher lymph nodes. There are few limitations in lymph node size assessment as well, because many times it has been found that lymph nodes smaller than 10 mm in short axis diameter are found to be malignant, while the nodes less than 10 mm or nodes 10 mm or more are reported to be benign. So in these cases, FDG PET CT helps to some extent in differentiating these hyperplastic or hyperplastic lymph nodes from the metastatic lymph nodes, but still there can be false positive lymph nodes even on PET CT in granulomatous disease like TB and sarcoidosis, especially in countries like India where TB is endemic. Sometimes when we have to grade the subcranial lymph nodes, it is difficult whether to label it as N1 or N2. As in 8th edition of TNM, the majority of data for N component was collected from Japan, which used the Root Japanese map, and they placed the subcranial space as N1, while the Mountain Wrestler American Thoracic Society uses subcranial space as N2. To overcome this difficulty, that we must follow a unified international lymph node map called IASLC map for all future categorizations, so as to avoid any discrepancies. And I hope you all are aware of this base lymph node stations as given by the SLC. In addition, there are few more features which are not addressed in the HTNM. For instance, features associated with poor prognosis such as the lymph nodes which have irregular margins, and sometimes even involvement of non-digital lymph nodes like lymph node groups in axilla, subpectoral, internal memory, diaphragmatic or abdominal regions. So it's not clear whether these lymph node stations are to be considered as M1 disease or as M3 disease, and further clarification is still needed. Then in the M descriptor, M1 is no metastasis, M1A is intrathoracic metastasis or contralateral lung nodules or pleural nodules, pleural effusion or pericardial effusion. M1B is single extrathoracic metastasis in a single organ, and M1C is multiple extrathoracic metastasis. There are many challenges in the HTNM staging system, especially when we have to evaluate the pleural invasion. There is still no absolute criteria to identify on CT scan how to differentiate visceral from parietal pleural invasion, especially in clinical staging. And the most accurate and the most elaborate CT finding for chest wall invasion remains the destruction of bone, which is not seen in many cases. The moreover, the present database has information on immunohistochemistry and molecular genetics. Also, it may be necessary to consider presence or absence of granulomatous lesions or synchronous or metaconous malignancies. To address all these issues, the 9th TNM is already being looked into, and it is expected to be scheduled for publication in 2024. New data elements such as patient environment and tumor-related factors like genetic biomarkers, protein alterations, and copy number alterations are added to the staging project for the first time, and many actions are being done to build a large, robust, and a detailed database to achieve these objectives and to come out with a more acceptable staging system for lung cancer. So to conclude, the role of imaging continues to evolve, and the radiologist must be familiar with the AFTNM system and its limitations so as to establish the accurate communication with the referent physicians, and the further collection of prospective data and detailed attention to unanswered questions will guide developments for future staging systems. Thank you for your time.